Hi, everybody. Good morning, and thank you for being with us today. As usual, we know it takes about a minute or two for everybody to join in, but we want to save as much time as possible for a really important topic today. We'll get right into our updates and start with Dr. Pinsky. Thank you as well for being with us today and every week.
Thank you, Errol, and good morning, everyone. I have a quick update on the variants that we've identified through the Stanford Clinical Virology Laboratory. It's been an eventful variant week. We confirmed 5 additional cases of the new so-called double mutant that was recently reported out of India from their equivalent to the CDC. In addition, we're continuing to see a large number of the 427, 429 variants in our population. And just yesterday, we identified our first case of the P1 or B1128.1 that was originally identified in Brazil. And we have 5 additional presumptive cases of that particular variant. And then finally, the B117 variant that was originally identified in the UK, we are starting to see an uptick in the number of cases with that particular variant. So we will keep an eye on that as we have continued to do over the last several months. So I'll take any additional questions in the chat, and thank you for the time.
Dr. Pinsky, thank you as well for your time and again for being with us every week. We appreciate the updates and answering the questions as well. Today I'll ask you to share those slides right now. Before we go ahead and talk about today's presenters, I want to mention that next week we do have Dr. Michael Liu. He's the Dean of School of Public Health at University of California, Berkeley, addressing violence on Asian Americans and Pacific Islanders. It's a tentative title, and we're really lucky to get him. As I mentioned last week, he wrote a really powerful email that's been circulated around extensively. And again, we're really thankful to have him. The following week, we have our own Dr. Julie Parsonet talking about herd immunity, kind of getting us to understand what exactly that means and what it's going to take to get there as we slowly get closer to it. And the week after that, we have Dr. Eric Gooseby, who's a member of Biden's coronavirus task force from UCSF, talking about how will COVID transform global health post-pandemic. But this week, we're really lucky to have 2 speakers who we've been doing a survey for a number of weeks, and for many weeks we've been asking people what is one topic that we want to hear the most of, and long hauler COVID has definitely been among the top or at the top. And we have 2 doctors, great experts to talk about that. We have Dr. Aruna Subramanian. She is the professor of medicine and chief of the Immunocompromised ID host service, and she's been in charge of that service since 2013. She's the co-director of the Stanford Myalgic Encephalomyelitis Chronic Fatigue Syndrome Clinic. And I wanted to emphasize, they note first thing on the front page of that website, a Stanford initiative dedicated to studying infection-associated chronic diseases. She spent over 20 plus years leading clinical trials, including back in the early 2000s with clinical trials involving AIDS and many aspects of that. She is no doubt an expert, not in just infectious disease and clinical trials, but the immunocompromised host as well. And I simply don't have time to go through all the different trials and publications, all the things that she's done, but let me just give you a sense of what she's done this past year. Dr. Subramanian was part of the Gilead's involved trial with remdesivir. She was early on involved with really a lot of the trials along those lines. She was involved, and it has been involved with the Regeneron trial. She's a co-PI for the J&J sponsored vaccine trial there. She also was involved in the trial with favipiravir, I hope I'm pronouncing that right, the oral antiviral, as well as a phase 2 study. Dr. Subramanian was one of the first people I tapped. She presented grand rounds in March 18th, 2020, as you can remember, a time where we were all worried and hoping for something that will help treat this virus. She talked to us about the antiviral treatment of COVID-19 and gave us the hope that we're not alone with this and we have things that can help us treat this virus, and we sure did. And so she's been a resource to me personally, both in medical ground rounds as well as on the wards, taking care of patients. I'm really indebted to her and thankful for her being here today. And along with her, we have Dr. Leanne Williams, She's a professor of psychiatry and behavioral sciences, and by courtesy also at the Stanford School of Medicine. She's the founding director of the Stanford Center for Precision Mental Health and Wellness. This is a center that connects researchers across the campus to advance high-definition imaging biotypes for mental health, sensor technology, and machine learning approaches. She's also the founding director of the Precision Psychiatry and Translational Neuroscience Laboratory, or the PAN Lab, within the Department of Psychiatry and Behavioral Neurosciences at Stanford. This creates a radical new way to understand and treat mental disorders, anchored in a neuroscience-informed model of precision mental health. She's also the Director of Education and Precision Medicine within the VA, with a joint appointment there. And she's the Associate Chair of Translational Neuroscience, Department of Psychiatry and Neurosciences. She leads many multiple department-wide initiatives in precision mental health. Like Dr. Subramanian, I don't have time to go into all the things that she's working and doing, but as you can see, both these doctors are the perfect people to talk to us about the question of, are we prepared for the long-term clinical consequences of the COVID pandemic, talking about the clinical and neurocognitive aspects of long-haul COVID. Doctors Subramanian and Williams, thank you so much for being with us today. We'll stop sharing our slides, and Aruna, Dr. Subramanian, will have you go and start sharing yours. And thank you so much. Looks good.
Thanks so much for that lovely introduction, Errol. And thanks for this opportunity to speak to all of you about this very important topic that's been such a long road for many of our patients. You know, as you said, we've become more comfortable taking care of acute COVID-19 over the last year, but we really need to learn more about how to help our patients with long-haul COVID. First of all, even just believing them and understanding their symptoms and reinforcing that these are real is so important to patients. But then what we need to do is really learn more, and I'm so happy to share what we know so far with you. So over the last year, we started taking this more seriously. I started getting referrals to our ID clinic last June, July, and then later to our chronic fatigue syndrome clinic. People with really persistent, ongoing, troubling problems. Science had a nice write-up about this last summer, talking about brain fog and heart damage. And then later, 60 Minutes had a fascinating segment on this whole topic. And many news outlets really picked up on this, including the New York Times. And then most recently, the Wall Street Journal, at the sort of year anniversary of the pandemic, interviewed a few of us about these patients who have been sick for the last year with ongoing symptoms. So I'll be going into the clinical aspects of long-haul COVID, and Dr. Leanne Williams will really be going into the neurocognitive, neuropsychiatric aspects, which are quite debilitating to people, probably the most debilitating of all the symptoms that we're seeing. So looking forward to that part. But let's start with, how do we define long COVID, right? It's a difficult definition. As you see at the bottom right of the slide, long COVID does overlap with some of the known complications of being hospitalized with COVID-19, like post-intensive care syndrome, having secondary infections, the MISC and Guillain-Barré syndrome, which we know are post-viral complications, but this is something more. The NIH has put out an initiative that many of us have joined, looking at PASC. They call it PASC, or post-acute sequelae of SARS-CoV-2. That's sort of the scientific name that they're trying to use for this. And they define it as patients who continue to experience a constellation of symptoms long past the initial stages of COVID-19 illness. Patient groups, however, have been talking about this for the last year and calling it, some call it long hauler COVID, some long COVID-19. There are various names for this, and that's also important. They're all referring to the same syndrome. And we'll be talking more about this. It's also very hard to understand what the numbers are. What are the denominators? Many of the studies we see are stack toward getting more patients in. So our numbers seem really large. This study from the UK is a nice one in Nature Medicine recently, where a mobile app was launched last March and 4.2 million people registered, so not a small number. They had 4,000 plus incident cases, and people recorded their symptoms over time. Most were actually back to normal, thankfully, in 2 weeks. But interestingly, 1 in 10 had symptoms lasting more than 4 weeks, 1 in 20 about lasted more than 8 weeks, and 1 in 50 had ongoing symptoms beyond 3 months. So this is quite a significant number overall when you think about the millions of people worldwide who are affected with this disease. They came up with a predictive model for who is going to have long-term symptoms, and really the risk factors were being elderly, female gender, and pulmonary comorbidities. And the number of symptoms in that first week also correlated with risk for long-term consequences. This is really an interesting multi-system, multi-organ system disease, and we see long-term effects in multiple organ systems. This is a meta-analysis that is still in preprint of 15 different studies where they looked at 55 different symptoms and consequences. The main one you can see is really fatigue and headache, which are really the most prominent symptoms long-term. But I'll be touching on some of the pulmonary long-term effects and a little bit about the cardiac effects. And there are also long-term GI effects. As I said, there are many neurologic and neurocognitive and neuropsychiatric side effects that we're seeing long-term that Dr. Williams will be covering later in the talk. And then if we get into individual key studies where we look at what symptoms we're seeing, it really seems consistent over time when you get into the details. So many of these studies were done in hospitalized patients that were discharged. This first one on the left is from JAMA, and it's from Italy. It was published last summer, one of the first studies in this area, which looked at 60 days post onset of COVID-19. And it was surprising that even 60 days, 2 months post follow-up, people were still complaining, a large proportion were complaining of fatigue, dyspnea, joint pains, and other symptoms. Then this study from France looked at patients about 4 months after discharge or after they were admitted, and it really is consistent: fatigue, difficulty breathing, memory loss, sleep disorders in large proportions of patients. And this involved men, women, and even some children. One of the largest studies was one from Wuhan, China, of over 1,700 patients who were now 6 months post-discharge from hospital. And yet again, you see the same types of symptoms: fatigue, dyspnea, and other neurologic issues. The interesting thing here is they did do pulmonary function testing, and the diffusion capacity was diminished, they found. Not surprisingly, those who needed non-invasive ventilation or mechanical ventilation were more likely to have lower diffusion capacities. But the interesting point as well is that the 6-minute walk test was diminished in people, whether they were admitted or not, even people with mild, these were all admitted people, but people who were not even on oxygen. So whether they were on oxygen or not, their 6-minute walk test was diminished. So that was an early, these are indications that some of these symptoms are not dependent on severity of illness. And this is something that's quite important to patients. Other individual studies do also replicate some of these findings, some of the long-term pulmonary effects. This is a study from Italy on the left of 200 plus patients, and half had functional impairment, which is pretty significant, 4 months post-discharge. 1 in 5 had diffusion capacities which were less than 60% predicted. And the risk factors for that were, again, female gender, having pulmonary comorbidities, or having been in the ICU. Another study from China of 55 non-critical, so pretty mild to moderate illness, 3 months after hospital discharge, found radiographic abnormalities in 71% of patients. And there's a figure there of some representative CTs that people were seeing 3 months after discharge, with lung function abnormalities in 1/4 of them. And it did seem to correlate with their initial D-dimers. The cardiac effects have been really fascinating as well, and the subsequent myocardial inflammation that was seen. There was a study of autopsy findings in panel 1. You see that paper. This is a combination of different papers. So the first one was an autopsy study where they looked at 39 patients after death and stained their myocardial tissue. They found actual SARS-CoV-2 virus, you can see in the brown staining, in 24 out of 39 of those patients. So large numbers of patients with actual direct viral effects, viral particles seen in the tissues. 2 months out, another study looked at cardiac MRI and found myocarditis and pericarditis. In panel 2, you see the yellow arrows referring to the pericarditis. The white arrows are referring to myocardial thickening, myocarditis. And they did actual biopsies, endomyocardial biopsies in those with severe disease. In panel 3, you can see they found lymphocytic infiltration, so significant inflammation, but no actual virus present. So it seemed like the virus is triggering some inflammatory response there. And that study and another study looked at cardiac MRIs. The initial study looked at 100 patients with cardiac MRIs and found 78% of those patients had abnormalities on their cardiac MRIs months after discharge. And in panel 4, you see examples of edema, fibrosis, and they even did see impaired contractile function in these patients who are getting cardiac imaging. In addition to the pulmonary and cardiac involvement, we know that there's GI involvement. All of us have seen patients with diarrhea and mild hepatitis, which is very common in the acute illness. We know there are ACE2 receptors present in gut tissue, so the virus does get in. And we've seen acute severe complications associated with mortality in the ICU, like mesenteric ischemia or GI bleeds. But what we don't know very much about are these long-term symptoms. In that meta-analysis I showed you in the very beginning, 12% reported long-term GI symptoms, and a larger percent reported nausea, which was not included in that. So there does seem to be some effect on the microbiome, but we are doing further studies in this area. And even in the chronic fatigue syndrome world, we talk about this brain-gut axis and whether there's some effect on that in this post-infectious state. And that takes us into the neurologic and neuropsychiatric long-term effects. Of course, in acute infection, we've seen patients with strokes and anosmia. And then the immediate post-viral syndromes like Guillain-Barré are something we look for, fairly rare, but something we watch for. In terms of long-term symptoms, though, we're seeing ongoing headaches and some people with ongoing anosmia. But the thing I really wanted to highlight was something called POTS, or postural tachycardia syndrome, which is something we also see associated with chronic fatigue syndrome. Some of our neurologic colleagues have a specific interest in this area, and Dr. Mitch Miglis from Neurology had published this case report of a patient who developed POTS after COVID-19. And on the right, you'll see a tracing where he did a tilt table test, and there was an exaggerated response in their heart rate. This is really pathognomonic for POTS and something that we see in chronic fatigue, as I said. The other neurocognitive depression and anxiety aspects of this, Dr. Williams will cover. So let's think about other post-infection syndromes. How is this similar to that? And there does seem to be some similarity. When you look at patients who had SARS in the last decade, they looked at patients 1 year after the outbreak in Hong Kong, and there were 175 patients. A large proportion did have psychological distress with moderate depression and at least moderate anxiety. And there too, healthcare workers were among the most affected. In a study from the Netherlands of people who were 17 months out from their outbreak, people still had fatigue, or they had developed new fatigue, neurologic symptoms, and post-traumatic stress disorder. And their health-related quality of life was really impaired. So there seems to be some immune dysregulation that's triggered by many of these infections. And what we're hopeful for is what we learn in long COVID will help us treat people who are developing these types of similar symptoms after other infections. But COVID-19 seems to be uniquely important in terms of developing some of these long-term symptoms. When in this very nice study, which was a retrospective study of patients in the US, looking back, a large proportion developed psychiatric illness, mood disorders, anxiety disorders after COVID-19. And when you compare it to other illnesses like influenza, the proportion is much higher of patients who are developing these long-term effects. And you'll hear more about this. This study was actually, there's a follow-up study that was just published yesterday in the Lancet there's even more data in this area now. One thing I wanted to highlight is that some of these symptoms, especially the fatigue, is not dependent on the initial severity of infection. So it's not that only hospitalized patients in the ICU are developing this fatigue. It's really people, including people with mild infections. So in this early study from Townsend et al., there were 52% of patients reported persistent fatigue at 10 weeks, and there was no association between fatigue and initial severity or their initial laboratory markers. And data from our group also replicated this information. We published this recently in Clinical Infectious Disease, that patients with uncomplicated or mild COVID-19 had persistent symptoms and functional impairment similar to people with severe COVID-19. So it's something that we have to deal with even in people with mild illness. We combined our data. I'll talk to you about the IRIS cohort, and with the lambda interferon follow-up cohort. So we had 118 patients, and we looked at about 4 months after their initial diagnosis. The nice thing about our study is that it represents a lot of the same demographics of the patients we're seeing here in the Bay Area. So half of our patients are Latino, and 47% were women. Only about 1 in 5 were initially hospitalized. So they were, a lot of them did have mild infection initially, and a large proportion were still symptomatic at that 4-month follow-up period. Especially if they had had dyspnea, they had more symptoms at follow-up. Interestingly, their 6-minute walk tests median was about 59% of predicted, so really diminished still at 4 months. And very importantly, their work productivity. Only about 1 in 10 were still missing work due to their health impairments, and 40% reported work impairment due to their health. So a lot of these patients, we have to keep in mind, were essential workers and are essential workers. So for them to have to miss work or have work impairments at 4 months out is very, very significant. And knowing that COVID-19 disproportionately affected the communities of color, this can be very, very important and something we really have to think about further. So our IRIS study that we started last June, July, and got funding from the ChemH IMA was, it has been a fantastic collaboration. It stands for Infection Recovery in SARS-CoV-2, so IRIS. And it's been a collaboration between infectious disease docs, immunology, pulmonary medicine, neurology, psychiatry. We do assessments at 3, 6, and 12 months. And these patients undergo a clinical evaluation, pulmonary function testing, extensive neurocognitive testing you'll hear about, depression and anxiety questionnaires. We look at their quality of life and work productivity. We do a chronic fatigue index, and a subset of patients undergo functional MRI, and we are banking bloods for immune phenotyping for all of these patients. And thankfully, we have excellent collaborators in this area where we're going to be looking at these patients. We've banked their plasma and PBMCs, and we're going to be looking at sort of immune profiling, looking at cytokine profiling, FC receptor profiling. We're going to be doing epigenetics, transcriptomics, and proteomic profiling, really to get some ideas of what is the immune phenotype, what can we correlate with some of the symptoms that we're seeing and the neurocognitive effects. Dr. Catherine Blish gave me this slide, and she's going to be doing a lot of the work on this along with Dr. Taya Wang and Angela Rogers. One interesting question that comes up is, do vaccines help in long COVID? And there's been anecdotal evidence that maybe people are having some benefit from vaccines. So this was a small paper that's still in preprint from the UK of 44 vaccinated patients and 22 unvaccinated patients with long COVID who were followed up 1 month after their vaccination. They got Pfizer or AstraZeneca vaccines, and many of them did have long COVID with persistent symptoms, but fewer reported worsening symptoms after the vaccine, and more reported symptom resolution after they got the vaccine. So 23% versus 15% actually had symptom resolution 1 month after the vaccine. So that was significant in terms of the difference. We'll have to see really how real this effect is and whether it lasts long term, but it's a nice tool in our armamentarium and a nice way to get people to get vaccinated. The NIH has put together this goal to improve understanding and develop strategies to treat and prevent these post-acute manifestations, and have many of us at Stanford, there's been a wonderful push to get this grant in and have different ideas for research in this area. So we're trying to understand the clinical sequelae and risk factors for severe outcomes, really recognize who's at risk for these manifestations, identify the pathogenic mechanisms and therapeutic targets, and develop early interventions and therapeutic strategies for these people. So we don't really have therapeutic strategies yet. Right now, we are being referred these patients in our individual subspecialty clinics, and we're each treating them in ways that are very, based on their symptoms, but not necessarily in a very systematic way. So a whole group of physicians have come together to put together this long haul COVID clinic, which is going to be multidisciplinary and involve not only support and treatment of patients, but also research projects and new ideas so that we can move this field forward. And Drs. Hector Bonilla and Linda Geng, I think, are really involved in in putting this together, along with help from lots of different people. So with that, I'd like to turn it over to Dr. Leanne Williams, who's my colleague. And of course, this has really been a wonderful group effort. The IRIS study team has involved lots of people, Dr. Phil Grant and the whole team, and the Lambda follow-up team, Lambda interferon follow-up team has been really instrumental in putting this data together as well. The IRIS Neurostudy information you're going to hear about from Dr. Williams, and thanks to the ChemAge IMA for funding IRIS and all the operational support that we've gotten for this. So with that, I will stop sharing. And
thanks, Dr. Subramanian. As Dr. Williams is putting up our slides, we already have, so usually questions don't start towards the end, but we already have 10. We're on course to have a record for number of questions.
oh gosh.
We won't get, of course, all of them answered live, but Dr. Subramanian, if you want to answer some in typing, and I can always still pull some back up and depending on how much time and ask them out loud, or you can leave some of them not answered for me to ask you out loud as well while Dr. Williams is talking.
Okay, thanks.
Thank you. And please, everybody, do upvote questions as well if you see a similar one.
Thank you so much for the kind introduction, Errol, and delighted to follow Dr. Subramanian's presentation. And thank you for the opportunity to share some of what we're learning about the neural and neuropsychiatric aspects of long-haul COVID. What I would love to share with you today are some early findings from the IRIS sub-study of the overall IRIS cohort, and aim to place these findings in a context of what we're understanding about mental disorders, how they have a physical basis in neural circuits of the brain, and how that gives us a way potentially to understand the links between mental disorders and the impact of novel viruses, such as SARS-CoV-2. Ultimately, as Dr. Subramanian highlights, we want this to inform patient care and the results, because by definition, we're looking at long haul, are ongoing. As Dr. Subramanian highlighted so clearly, the data really are concerning about the mental health impact and whether it's another wave of COVID-19. And we see this in terms of the higher incidence overall psychiatric illness, and also mood disorder and anxiety specifically. Yesterday, as was mentioned, Lancet Psychiatry published this very impactful study, over 200,000 survivors. It's an electronic health record study, and it's showing that effectively 1/3 of people at 6 months post-infection are experiencing clinically significant levels of depression, anxiety, and cognitive problems. And this is obviously a very large study. What is unknown yet is what may be underlying this. And this is leading us to look at individual cases and then the IRIS Neurostudy that I will talk about. So if we think about the individual experiences, this is one example, and there have been many in the media and many that you will have heard about directly. So in this case, Heather Petit talks about this concept of mental fog or brain fog, and how it's literally disrupting the ability to think and talk and concentrate. And it's leading people to really not understand it and feel like life's really not worth living if this is going to persist. And I think the unknown aspects of it really feed into that, that quote she has, who in the world would want to live like this? Let's put this in context of what we know about the base rates overall of the disorders that I'll focus on, which are depression and anxiety. So if we look at over a 12-month period of prevalence, in the United States alone, depressive disorder accounts for 10.4%. That's approximately 1 in 10 young adults through to older adults. Anxiety disorder as high as nearly 25%. Lifetime prevalent rates are more like 8% for depression and 17% for anxiety disorder, and they have a very high overlap, so as much as 80%. But still, it's affecting a lot of people. So if we look at this picture globally, it's not surprising that these disorders are accounting for their role as, unfortunate role of the #1 cause of disability. That's a lot of lost talent in terms of global economy and people's lives. It's a chronic illness typically, and 1 million suicides globally per year. Aruna beautifully showed the constellation of symptoms that we see long-term from COVID-19. And of these, a significant subset are either neural or neuropsychiatric. So this yellow highlight shows the subset that are related to mental disorders. And I'll come back to this point later in more detail, but I do include memory loss in this. And I highlight that although when we think of depression and anxiety, we typically think of the mood symptoms, if we look at the diagnostic criteria, it's apparent that cognitive features they are part of the diagnostic criteria. So concentration problems are diagnostic for both disorders, and those involve executive function problems, problems with memory, and problems focusing attention. I won't talk today about the sleep problems that are also diagnostic for depression and anxiety, but certainly that's relevant in thinking about long COVID. So to turn to the specific IRIS Neurostudy, it is a sub-study of the overall IRIS cohort that Dr. Subramanian mentioned. And it's been possible to do this sub-study because of the unique collaboration that she highlighted. And this collaboration spans psychiatry and behavioral sciences, which is my base, neuroradiology, infectious diseases, and will no doubt span multiple other disciplines as well. So thank you to the investigators shown here. It's also possible because of the access to the IRIS cohort and the infrastructure that's made human subjects research possible in difficult times, as well as the funding from ChemA, IMA. We have a very particular theoretical framework that's informing this study, and I would welcome questions either after the rounds or offline, and there's more on our center website here. This framework is how we're moving towards a more precision health, precision medicine approach to psychiatric disorders, very much inspired by other areas of medicine dealing with complex and stigmatized conditions. So on the phenotype level, we have these different diagnostic criteria that arguably reflect different phenotypes that may arise from different pathophysiologies. And in the current diagnostic system, they do tend to be lumped together. So broad diagnosis of depressive disorder could arise from multiple different underlying causes. Our goal, both in research and clinical translation, is to then add these objective measures. So today I'm highlighting the neural circuit level, which is the functioning of the brain's circuits necessary for regulating emotion and cognition. And these are, if you like, the organ of interest when we're thinking about mental disorders. And we connect measurements using functional MRI and structural MRI of the neural circuits to self-reported symptoms, observed symptoms, and also to how these circuits are expressed in behavior. And that includes neuropsychological assessments. Ideally, we include measures of physiology because depression typically goes hand in hand with disruptions in heart rate variability and autonomic changes, blood markers, as I will touch on more, and the important contribution of life factors, so the role of stress, which I'll also touch on later, and other life factors. We then apply computation theoretical approaches to integrating these data. And in an ongoing way, myself, our lab, and other labs are identifying what we would think of as biotypes. So arguably more coherent subtypes that link the phenotype to the underlying biology and allow us to think about rational treatments and more personalized diagnoses. So how does this apply to the IRIS Neurostudy? As I said, we're extremely fortunate to have access to the overall cohort, and that gives us the clinical details, including hospitalization, severity, and so on. It gives us the blood markers, and it gives us a warm handover between the coordinators and the patient. So we screen for eligibility, such as for MRI, and then we arrange in-person visits. And at those visits, we would then add in the 3 layers of assessments I was talking about in the last slide. So we would look at self-report in terms of depression and anxiety. We would look at behavior in terms of neuropsychological tests. And in terms of neural circuits, using MRI to both get a high resolution structural image of the brain and functional MRI. And I'll pause a moment about the functional MRI. So you can think of what we do as somewhat similar to a stress test, but for the brain. So we look at what the brain is doing at rest, and then we look at it under different task conditions. And that gives us a way to look at what are thought of as large-scale networks of the brain that coordinate together, or regions that coordinate together to allow us to regulate emotion and thought and cognition. And what we've developed through my center is a means of quantifying those circuits at an individual patient level in terms of activation of regions that make up a network, the connection between them, and then referencing those scores to a healthy norm sample. In terms of when we assess the patients, we bring them in post-infection as soon as possible, and then the repeat assessments occur over time, 6, 9, and 12 months, and we've just started the 9-month follow-up. Because those follow-ups are small, today I'll focus on the initial assessment, which is typically within 3 months. This is the current sample that I will focus on, and these are the demographic characteristics. It ties back to what Dr. Subramanian was showing of the breakdown of the sample, with just under 30% hospitalized. And as I mentioned, the assessments are ongoing. What we see, I'll walk through the different types of findings. So if we look at psychiatric symptoms, we assessed these symptoms with multiple measures. I'm focusing on ones that are most commonly used in the clinic. So the PHQ-9 for depression and the GAD-7 for anxiety. And we assessed, as I said, this is within 3 months post-infection. 27%, this is close to 1/3, are reporting clinically significant depression and anxiety. So within the range that you would be meeting diagnostic criteria. And this aligns with the Lancet, much larger sample of 200,000 or just over 200,000 in an electronic records cohort from the UK. What we do notice is that depression is slightly more severe in the hospitalized patients, but this is not a consistent profile. It seems to be largely independent of hospitalization. Now I'll take a brief sidestep and just take some water. So led by Dr. Max Wintermark, Chief of Neuroradiology, and Bing Zhang, a fellow working with Dr. Wintermark. These are some of the findings from the brain structure MRI. And what we're zooming in on here is the olfactory bulb, which when the clinical reads are being done of the patient data coming through, this is something that's been standing out in the clinical reads. So on the left, marked by A, would be a normal size olfactory bulb. On the right, marked by B, is the smaller olfactory bulb that's being observed. And if we look at the patients so far, we see that not all, but certainly a striking number have this small olfactory bulb, and they also have the loss of taste and smell. Now that loss of taste and smell is present in all of the patients that have come through scanning so far, so unlikely to be an exclusive underlying cause, but certainly it's a finding that's striking us as being worthy of more investigation. Now to turn to the cognitive functions and associated neural circuit function with fMRI. If we look at the neurocognitive impairment, so this is done on a computerized version of a standard neuropsychological test battery, we see a similar amount of the patients, approximately 1/3, 32% to be precise, have significant impairment, and it's in aspects of executive function. And if we drill down, what's accounting for those are particular areas. Noticeably, these cognitive impairments did not differ with whether or not patients were hospitalized. Here's a more granular view. And these are quite significant impairments if you take into account that the healthy norm is 0 because they're standard deviations. So the most significant impairment is in attention, which is the ability to focus and sustain attention on important tasks. It's measured by a continuous performance test. The next most significant is working memory, assessed by digit span, and it is what we rely on to remember numbers, passwords, where our keys are, etc. Then we see some impairments still quite substantial at 0.4 standard deviations on average, in processing speed being slowed, and in complex executive function with patients performing a maze task. We look at what might be underlying these impairments. So this is with the functional MRI, and during the MRI, we run this so-called stress test. So one task would be a task called the go, no go, where we specifically probe cognitive control or the ability to engage in executive functions. And in this case, the requirement is to inhibit responses when it's red and press when it's green. And this is a task that reliably engages what is a circuit in humans that we need to be able to engage in executive functions, the cognitive control circuit. What we see in the patients assessed so far is a very striking underactivation of the regions that make up this circuit. And those regions are within the frontal cortex, necessary for planning and executive monitoring, and in the parietal regions of the brain. The yellow highlighted part is where we see a kind of normal level of ability to just press the buttons in the task. I tie this back to the theoretical framework of the biotypes. So this characteristic pattern of underactivation is what we see in one type of depression, this one over here, which we think of as cognitive dyscontrol, and may be implicated in these concentration and cognitive aspects of depression, anxiety. When we looked at the brain at rest, we also saw a disruption of what we call the salience circuit, which is associated with physical signs of anxiety and overall negative mood. Well, let's see if we can tie this back to the pathophysiology of long COVID as outlined by Dr. Subramanian. So here on the kind of tissue damage side, we see the lower olfactory bulb size, smaller bulb size, and potentially with loss of taste and smell. And then over here on the functional side, we see the quite substantial depression, anxiety, to be determined whether a prior history of psychiatric illness actually exacerbates that. And then the cognitive impairments coupled with these neural circuit disruptions And we need to understand why this is happening. So we don't yet have the answers, but some ways we could think about it are structurally whether we are seeing some form of neuroinvasion, where the virus is actually able to enter the brain. And what's relevant when we see the smaller olfactory bulb is that one entry point may be through the olfactory nerve. And of course, there are others through enteric neurons. If we think of the functional consequences, we know a little bit more about possible mechanisms in depression related to inflammation and stress. So there are at least two pathways by which depression develops. One is repeated exposure to uncontrollable stresses, and they will disrupt the circuits that we see disrupted in long COVID and create the symptoms that we observe. The other pathway, which is more recently being characterized, is the effect of inflammation following infection. And this may be one relevant to long COVID, and potentially we have a situation of a double whammy. So if you think of post-COVID, you may have inflammation plus the uncontrollable stresses of the pandemic, potentially loss of income, uncertain housing, homeschooling, social isolation, etc. So potentially a double whammy explaining the high rate of depression, anxiety. And we have mouse models for this, not that you can ask the mouse if they're depressed or anxious, but there are models where you would give a virus as a way of modeling inflammation and subsequent depression. So a few ways that we can put this in context. One way that we want to expand on with iris neurostudies to look more at inflammation and other blood markers such as C-reactive protein. And we do see that in long COVID, a significant number of patients have increases in CRP, and they also have depression. And if you look at depression alone, CRP is chronically increased in a subset of depression, and those are the patients with the cognitive impairments and the worst outcomes on standard antidepressants. So a possible route for how this could occur is with immune cell migration across the blood-brain barrier, particularly if it's damaged. But of course, this is an area that needs work. So our next steps are to think about how might this all come together in individual patients. And we're gathering these data, and here's just one example of a 40-year-old female who had a severe clinical profile. And she shows all of those indicators that I've been talking about: the high CRP, depression in the clinical range, prior depression, very impaired cognitive performance, and neural circuit function impaired. So our next steps, there are many, and of course we want to understand more about the mechanisms. We want to ask if the structural and functional indicators we see in the brain are causal for the symptoms. We need a deeper dive into psychiatric history and comorbidities, including with other physical conditions, comparison groups that may not have had COVID, but other viruses. And then of course, the treatment trials that will be so important, and looking at treatments that may target these particular disruptions. I'm hopeful that one consideration is that although this is a kind of gloomy picture in some ways, neural circuits are plastic, they are changeable. So if it's a functional disruption, we can think about how to target treatments that can boost the plasticity and reconnect and re-engage the activation. So let me end with saying thank you again to the collaborators. Thank you to IMA for the funding that made it possible, the study participants, and our incredibly hardworking coordinators. And I very much look forward to your questions and your collaboration as we go forward.
Thank you, Dr. Williams, and again, Dr. Subramanian, for those excellent presentations. Dr. Subramanian, thank you so much for answering a number of those questions. I'm going to jump right into questions right now, and I'll perhaps jump into probably the most important ones. Dr. Weinberg is asking, and I'm going to tie in a couple questions together. Danny also asks, so Dr. Weinberg is asking, and this was touched on a little bit, what is the evidence of any treatment interventions administered during acute infection aimed at the virus, antivirus antibodies, dexamethasone, can help the incidence, severity, or clinical spectrum of long-term symptoms? And kind of tying on that too, Danny had asked, how long is this going to last? What evidence do we have? How long is this going to last for many patients?
Mm-hmm. Yeah, these are great questions. We're looking at it in our long-term studies. As I said, there are patients who weren't even hospitalized, so many of them didn't get any treatments early on, and still they have long-term symptoms. So whether there are interventions we can do in patients with mild infection that will help long-term, we really don't know yet. When we look at our small data sets, it doesn't appear that people who got any particular treatments had difference in their long-term symptoms, but really we need larger numbers with longer term follow-up and better understanding. And hopefully, as we get more information on the immunology behind this, we can understand where we can intervene and how we can change things early on to prevent some of these symptoms. And we don't know numbers yet, but there are still very few people, but who are still symptomatic at 1 year, but they are quite debilitated, those who are still symptomatic at that point.
Dr. Leibowitz is asking, are electronic or tobacco cigarette smokers more severely affected by pulmonary residue?
You know, smoking is a risk factor for acute infection. I don't know that it was teased out in the long-term follow-up studies. COPD is a risk factor, so I would assume smoking would be as well.
I have a question here. Does long-haul depression respond to the usual antidepressant therapy, Dr. Ringgold?
I was just reading that question. It's a great question. We don't have evidence to be able to answer it accurately. My speculation is no, because the indicators that we see in long COVID are indicators that in depression without COVID do not respond to standard antidepressants, at least disproportionately do not. So I think there's some newer antidepressants that could be considered, ones that are more effective for, say, the cognitive features of depression. And there's emerging evidence for using some forms of anti-inflammatories as well.
Question here, are there any studies looking at CSF with PCR method to evaluate the presence of antibodies to SARS in long haulers or in acute patients to see if the virus is present in the CNS? You talked a little bit about direct invasion.
That's a very interesting question. We haven't been collecting CSF. I mean, it's been hard enough to bank blood, PBMCs and plasma, but that's all we've been doing. I don't know of any other studies. We are going to be collaborating with neurologists, and maybe that would be something, at least in a subset, we could do.
Excellent. Dr. Stockdale asked, the constellation of symptoms are the same as women given chemotherapy for breast cancer. Are there any correlates?
That is super interesting. And that's a side issue I've thought about with ME/CFS post-chemo, you know, that the severe chemo fatigue and whether some of the mitochondrial dysfunction you see after that, if we could really look at things that would improve mitochondrial function in both chemotherapy and chronic fatigue syndrome is an interest of mine. And I think in terms of long COVID, it would be a way to look at that as well. So hopefully what we learn from long COVID will help us in other post-infectious syndromes and maybe even post-chemotherapy type syndromes.
I want to, as we wind down, we have a couple minutes left. I just wanted to, Dr. Subramanian, thank you for going and answering a number of the questions in type. If there's any you wanted to highlight, we're going to send this out in response to everybody. I just wanted to say thanks to Dr. Barman. Had mentioned a question about and Aruna, you answered the depression. Is it from the pandemic? Is it from a mix? And Dr. Williams, you actually ended up commenting on that in your slides. And also, Dr. Barman had asked about referring patients to this clinic. It's being, and Dr. Subramanian, you talked about this as well towards the end of your slides. There is a new clinic being formed. We can certainly help share the information when it goes live.
Great.
In the meantime, patients can be still sent to individual clinics until we have a formal clinic.
Right.
As we wind down, I wanted any other comments or questions. Dr. Subramanian, thank you again for answering all these questions. Any that you wanted to highlight out loud? Otherwise, we'll send those out to everybody.
Not really. That's what I was going to say about referrals to the clinic. I think that's the main question people have is how can I help my patients, and whether we can get them involved in these studies. Our IRIS study is completely enrolled, but we are trying to get to expand it to enroll more people. And then through the PASS clinic, we'll be able to do studies and follow patients. So I think that's very exciting to have this opportunity.
Wonderful. There's a few questions left unanswered here. We can email them to you after, and we send all the responses as a follow-up with the live videos, the recorded video as well. Dr. Subramanian, Dr. Williams, thank you so much for all the work you're doing, and thank you for being with us today. Everybody, thank you for being with us as well. Hope you have a great week.
Thank you.
Thank you.